Hey everybody, we're going to wait for a bunch of people to come on because we are going to be talking at 7 o'clock. Hi everybody. Hi Jalen Andrews. We're going to be talking tonight to Dr. Josh Hurwitz. In fact, I'm going to pin his stuff. Hi everybody. I love seeing you guys come on. I got to tell you, it's so fun to all of a sudden see people come on. I want to pin this comment. I just learned how to do this. Hi, Dr. Hurwitz. Do I have to let you in? Dr. Hurwitz joined. I'm waiting for him. Hi, everybody. It is Thursday night when Dr. Hurwitz joins on, Dr. Josh Hurwitz from RMA, Reproductive Medicine Associates. We're going to talk about fertility stuff, in particular anti-Müllerian hormone, which is a newer hormone from when I have become a physician. Like when I trained, it was not part of our world. Okay, you joined, Josh, but you need to ask to join me live, Dr. Hurwitz. Dr. Hurwitz should ask his teenage children how to do this so that he can actually be here with us. And guys, any of you who haven't met him will love him because he is, as I joke, a yenta. He loves to talk. He loves to engage more than I do almost. And he's deeply excited to have his patients be successful in trying to get pregnant, which is nice. It's not just a business for him. He really cares. So as soon as he comes on, we're going to be talking about how to... I see that you joined, Josh, but you didn't join the live. So we're going to be talking about... up here. There. Was it me? Waiting for him. So many women, when they're young, will say things to me like, oh my God, I'm so nervous and I'm so scared I'm not going to be able to get pregnant. And I'm glad that I can say to them with confidence, why would you think that way? The vast majority of women will be able to get pregnant. Sometimes people need help. So I can never say whether or not someone's going to need help getting pregnant, but I can say with confidence, the likelihood of not being able to get pregnant at all is incredibly small. So any of you out there who are joining us, if you are trying to get pregnant or are worried about getting pregnant or have a friend or a sister or a daughter or a niece, please just remind them the likelihood of not getting pregnant is very small. That does not mean every woman will get pregnant on her own. Many women will need help getting pregnant, and that's okay. The good news is that we luckily have people in our world who can help us. I don't know what just happened. Allie Hurwitz, I see that you're there. Help your technologically, you're working on it. All right, he's working on it. In the meantime, oh, yes, you want me to save this live. I'm going to try to save this live. I don't know who else here is really good at Instagram, but since I'm just learning, I've learned that you can save the live right after you're done, but somehow I think if you go over an hour, you can't save it because I went over an hour 2 days ago and I couldn't save it, so I had to screen record it. Okay, so getting back to this until Dr. Hurwitz manages to join us. Hi, Christine Joy. So when, Allie, he's working on it. So again, when people press request to join, yeah, Josh, someone's telling you press request to join. Yes, and someone just wrote here, he really does want you to get pregnant, right? He really does. He's so excited about it. So again, the thought of young women worrying about their fertility makes sense to me because I think there's so much media attention about it. And I think the fact is many of us, as we get older, because we're getting pregnant older or trying older, getting married older, and our careers make us delay getting pregnant, I think it's really natural to then see people around you having trouble, and that increases anxiety instead of calming us down. As you guys know, I'm a big proponent of let's be calmer about it. You requested twice. I know, Josh, and I accepted, but there's no more requests here. Tell your young... Okay, guys, sorry, hold on. Josh, I requested, but I don't see the request anymore. So try it one more time. Here. Go live. It says it. Let me... connecting. There he is. I thought it was me, but it wasn't. Thank you, Allie.
Zoe Hurwitz, actually, my daughter
Thank you,
Zoe.
All right.
She actually looked it up. I literally requested 3 times. I'm sorry it took me a minute or anything.
Whatever. Virginia down there, your media person is like hanging her head. Okay. Hi to everybody.
Awesome.
Let's start over. Okay. Hi, guys. So you guys know me. I'm Shieva Ghofrany. This is my friend, Josh Hurwitz, who is truly a total yenta, mensch, every Yiddish word I can think of to imply just a good soul who really wants what's best for his patients. I think everyone who knows, there's a couple of your people on here, your fan club. And so the reason this came up is in the last couple of weeks, even a lot of patients happen to say, tell me about AMH. What's going on with AMH? What does it mean? So we need to cover a couple things, and I'm going to let you say hi after this, but I want us to cover, I have our notes. We're going to talk about what is AMH? What does it predict? Does it really predict what we thought it would? Does it have an indicator for fertility, for your response to fertility treatment, for perimenopause, menopause early, and PCOS? So those are the AMH questions. And then I do want us to have a little bit of a discussion of, and I think I know what you're going to say, what should we do in the future about addressing young women's fertility concerns? Because I think on one hand we should address it. On the other hand, I have mixed emotions about putting too much pressure. So if we have time for that, we should talk about that.
Sure. It's only about 4 hours worth of material.
Sure. We can talk that long. I know.
So I'm going to tell a very quick story about how Shieva and I met real quick. I'm sorry. So in 2006, I graduated fellowship at Albert Einstein College of Medicine for reproductive endocrinology, moved to Norwalk, the first job I ever had. And I was at a mutual friend named Monica's Kentucky Derby party.
I love Monica.
And my wife, Allie, and I met Shieva and Charlie there. And we knew like someone in common that wasn't there that we're supposed to meet. But it was like, honestly, like love at first sight for all 4 of us. And the thing I love about Shieva is that you are as authentic and amazing in your personal life as you are in your professional life, and that's why everybody loves you. And the other thing I love about you is that there's not every couple do like the husbands and wives and back and forth get along as well. And I love Charlie as much as you. And we were alone in Connecticut almost. You were like the first sort of non-work person I had met. And now we both like are in each other's lives, but also work together, which is like amazing. So thank you.
I know. Well, I love you. And actually, I will tell a quick story. Guys, do you see the words all over Josh's face, though? Because I pinned your name here so that it can stay up. But then it makes all the words. So
it looks better with the words on my face. Trust me.
I'm going to take that off, but so everyone knows it's Dr. Hurwitz, and we'll post about that. Really quick, my fun story is that when I was back, I was 250 pounds, you guys. And I called Josh Hurwitz to say, oh, I don't know what to do. I don't want a 3rd baby, but I'd really love to have a girl because my husband wants it. Long story short, he said, sister, maybe you need to lose weight first. He didn't say it like that, but he said in the most gracious way, have you thought about losing weight and doing surgery? And that was when your beloved mama, Margie Hurwitz, I don't know if she's watching, told me to get the monkey off my back, do surgery, and lose weight. And lo and behold, then I got all knocked up by surprise. So that was another fun Josh Hurwitz story. Okay. Much ado about our crazy lives. Let's talk about AMH. Tell us about it.
Let me address some of the things. First, let's talk about like what is AMH. Everyone's heard about it. It's literally in People magazine these days. Like Kim Kardashian talks about it. So it's a thing. It's crossed over from the scientific world to sort of the real world, right? So AMH is a hormone. It's present in both men and women, but it really makes a difference in women and not really in men. So we don't talk about it in dudes. Basically, every single egg that a woman has left, which is encapsulated in a little fluid pocket called a follicle. Each egg and follicle that a woman has left secretes a little tiny bit of AMH. And so each egg secretes a little bit, so it adds up in the bloodstream. And the higher that number, the more eggs a woman has. That's basically what AMH is.
Oh my God, I got to tell you, as the gynecologist who thinks I know, I never thought of it in that term. So repeat that for all of us.
Sure.
Didn't get it. So the amount of hormone is in each little follicle.
So each egg and follicle secretes a little tiny bit, or what we call a quanta, or a bit of AMH. That AMH gets released into the bloodstream, goes throughout the whole body, but each egg and follicle, contributes its own amount, but it adds up in the bloodstream. And you can use that as a gauge for how much gas is left in the tank. The higher it is the spread, the lower, the less. Yeah,
okay.
Exactly.
Okay, good. Well, so that was the question, like when I had heard about AMH probably 6 to 8 years ago. Does that make sense? What we were taught, I'll tell the public, what we were taught or encouraged to do is check the AMH. If it's above 1, someone had good ovarian reserve. If it was below 1, maybe their ovarian reserve was decreasing, and therefore that would be an opportunity to say, go see the fertility specialists. right? So it held a lot of promise, and it sounds like, tell us, did it shake down to be as good an indicator as we thought?
Well, so it's everything you said is completely true, but it's now a little bit more nuanced. Let's put it that way. So the idea behind wanting to know about AMH is that there's a story of the biological clock, and it's a story that we all know really well. And a very quick story is that, both men and women have a biological clock, but for men, it ticks a lot slower, right? Men retain the ability to make sperm throughout their entire lifespan. Totally unfair, right?
Weird. And by the way, weird. Who created us? That was so weird and dumb. I mean, it doesn't make sense.
Right? Really? Probably why God is usually referred to as a he rather than a it.
Yeah, we don't believe it. Mm-hmm.
Right? And then conversely, though, women do not retain the ability to make new eggs throughout the lifespan, right? So they're born with a finite number of eggs, and they have to last a lifetime. Right. And unfortunately, as we all get older, nothing to do with any one person, I don't want anyone's ovaries to get defensive or anything, there's a decrease in both the quantity and the quality of eggs as she gets older. And that's what the biological clock is about. And so AMH was not invented, but it was sort of discovered and used as a gauge to understand what an ovarian reserve might be as a snapshot in time for a woman's how much gas is left in the tank or how much time does she have in the biological clock. That's how we've thought about it for a long time.
Right. Well, and do you feel like then it's been helpful? In other words, when we send those patients whose AMH are less than 1,
yep,
and you guys do your workup, tell us which patients are you going to be more worried about and less worried about?
So in general, the higher the AMH, the better, within some limits, which we're going to get to later, right? And the lower, the worse. So over 1 is considered normal, and below 1 is showing some weakness. And once you get below 0.5, like 0.4, 0.3, 0.2, or undetectably low, severely weak, right? So we thought the story was as easy as that. High AMH good, low AMH bad. If your AMH is low, doesn't matter what age you are, hurry up and see a fertility specialist to freeze your eggs, or hurry up and get pregnant, or hurry up and do something that you weren't thinking about doing as a call to action.
Right.
It has been a little bit more nuanced. When we look at AMH levels in the entire population, like all comers out there in the world who may or may not be trying to get pregnant, like an unselected population of thousands of women,
right?
It turns out that the people with high AMHs and low AMHs probably did about the same within certain age bands of getting pregnant, right? Now that doesn't include someone who's been trying to get pregnant for a while and has not had success.
Right.
It doesn't include people who are probably over 35-ish.
Okay.
Right? And so it's not as simple as saying if you have low AMH, you're doomed to hurry up and do something drastic. You can still probably do fine with natural fertility. But what we do know is that those women are going to be patients who later on will probably unmask themselves as having trouble, right?
So can I interpret this? Do you mean, so if I have 28-year-old, she's in my office, she has no plans of getting pregnant, and she says, can you do this test?
Yep.
Assuming she's never tried, assuming she has a regular period.
Yep.
And I happen to get a 0.8. There's no reason necessarily to think she will be at risk, although as she gets older, then it might occur.
Here's the nuanced version of it is that let's say that woman wanted to get pregnant then, and a woman at, let's say in your example, 28 with a 0.8 versus a woman who's 28 with a 1.7, okay, which would be a nice strong number, or 2.2 or something like that. If they were both trying to get pregnant over the next 3 to 5 years, they might have equal chance to get pregnant.
Okay. But if that 0.8 when she gets older?
Sure. That's going to unmask. And the older we get, the more that's going to exacerbate, for sure. There's no doubt about it. And the reason why I bring that up is that there was a study done from a well-known research group that did a really good job, and it's been an influential paper. It came out about 3 years ago that said that AMH may not be like the end-all, be-all, like how much gas is in the tank, like meter on your dashboard in your car that you thought it was. Well, probably anyone with a low AMH deserves the same conversation that I know you give your patients every minute of every day, but they probably deserve a talk from either you or someone like me where they would get a complete and thorough evaluation of their total ovarian reserve and fertility potential. That includes another hormone called FSH, some estrogen levels, an ultrasound to measure the size of their ovaries and how many follicles, which are those little fluid pockets that hold the eggs, are visible on ultrasound, and the age. And when you put that all together, and again, have a conversation with that woman, what her ultimate goals are about when she wants to start building her family and what she wants her ultimate family size to look like, that's when you get a more complete picture of ovarian reserve. And you can really counsel that patient, hey, this looks like lower than 50th percentile. This looks lower than 20th percentile. Wow, you're in really good shape, or wow, you're in really bad shape. So I think it's the opening of a door to have the larger conversation. I don't think it's one number that you can pin all your hopes and dreams to.
Right.
That cuts both ways, right, Shiva? So if it's amazing,
Or if it's high,
can't say for the rest of my life I'm off the hook, don't worry about it.
right.
And if it's low, let's say it's really low. Let's say it's like less than the 25th percentile for someone, even though they're young. You also cannot doom them to say you'll never have children.
Right.
You can let them off the hook both ways.
Right. Well, and I think that's an important point for anyone on here who is young, who might have heard or will hear that their AMH is low. Like one of my favorite stories that you and I took care of was a woman who was 48 who had an AMH of 0.03. She was very happily waiting for her donor egg, and she was going to have a baby with a donor egg and her husband's sperm. And lo and behold, she got pregnant spontaneously, and she had a beautiful, healthy 9.5-pound baby with no Down syndrome or anything at 48. Now, of course, it's an anecdote.
She slipped one half goalie, that's for sure.
Yeah, really. And so it can happen, which doesn't mean, I think Josh would agree, like none of us would say like, don't worry about it. But we would say, you can keep hope, but also be proactive, right? But so again, Josh, I guess the part that's confusing to me as the gynecologist is if I send you my patients, let's say who's 28, AMH of 0.8, let's say all those other parameters, her FSH, her follicle size, number are okay, you would still encourage her to freeze her eggs if she could financially, because we don't know what's going to happen later?
So that's a very big question, okay? So basically, egg freezing is a thing these days, obviously. It's in on social media. You talk about it with your patients and your followers all the time. So I've had about 4 conversations in the last 3 days with patients about what we call elective oocyte cryopreservation, which means egg freezing because you're not ready to have a baby yet, but you want to retain all your options and maintain your fertility potential in the future.
Right.
We also actually, my office did an Instagram live on this last week, which was, so this is like my second Instagram live ever. So thanks
so professional.
Yeah. Hence why I need my daughter to like help me get on.
Yeah, really.
So basically, egg freezing is absolutely an empowering procedure where you can stop the clock and you can put away 10 to 20 eggs, which will maintain your fertility potential later on in life. It will take the pressure off your life and your anxiety, take the pressure off your dating life. So you're not like sitting across from a guy having a glass of wine thinking, do I need to hop into bed with this guy? Right?
Yeah.
And even more importantly, right? Like when you're swiping right, you don't have to worry about, is this like Prince Charming, right?
Bad idea, right?
Right. And then the other thing is it maintains reproductive autonomy. Those frozen eggs can be fertilized with any future sperm source. So when you get married, a future boyfriend, donor sperm, there's lots of different ways to build families. Now, I do not think that every woman with a lower AMH needs to run to do egg freezing. It's part of a larger conversation that would go like this. Hey, let's do that thorough evaluation. Let's look at you in a 360-degree view. Let's talk about what your goals are and when you want to start. So if I'm talking to a woman, I just talked to someone on Monday. She is a third-year med student. She's got 2 more years of med school. She wants to go in a really high-powered residency. She wants to be a neurosurgeon. She may take 2 years off to do research to help her get a residency. So she's looking at 9 years of training ahead of her. She does not want to have a baby, at least at the beginning of her residency or anything like that. She said, I want to freeze my eggs. And I said, that's a great idea.
Great idea.
Great idea.
Which, we could have a whole conversation about egg freezing and the pros and cons, right? So, okay, so AMH, if it's low, what has
I think it's a call to action. It's a red flag and a call to action. It's not the end all be all. So I'm skimming through the comments as they're going through. And I don't want anyone with a lower AMH to be terribly worried. It is not a deal breaker at all. That's what she and I are trying to get across. It is not a doom and gloom. It is not a deal breaker. It may be a call to action. And that
be proactive, as we say, right? Go see a specialist, get more information. And then.
Now, and then make some decisions. And it might be the call to action would be to have that conversation every 6 to 12 months. It might not be egg freezing this second, right? But
and it doesn't mean a low AMH doesn't mean you can't use Clomid or Femara, the oral medications. Is that correct?
A low AMH does not indicate you need to go right to IVF. I want to be very clear about that. One of the things that I talk to patients about, and they're nervous about coming through my door. It's hard to make an appointment and walk through my door. It really is. And I'm very proud of any patient who does. And I'm very proud of everybody who's on here listening tonight. It's a hard topic, right? But what I'm getting at is that just to come in and start the conversation, right? And the idea that if you go see a fertility specialist, that means you have to do IVF, that's not what we're talking about.
Right.
There's lots of treatment options from the lowest to the highest,
right?
Right? And they'll be tailor fit to you and what you want to do. But Dr. Ghofrany's point is really well taken. Just because the AMH might be on the lower end does not mean you need to jump into IVF at go. It does not mean that.
Well, and I always, listen, this is why I send so many people early on to you guys, to fertility doctors, because I think most women, and I speak very broadly, but most women really do like information. So when they feel like they have the information, then it tends to help them feel calmer, because then they know, all right, now I have a backup plan. I'm going to, and I say to many of my patients, go see these guys, get your information, get all the workup. You might not need to do anything, or you might choose not to do anything, but at least then you've figured out some of the information. And often, as we know, they get pregnant on their own in the midst of it.
So knowledge is power. You and I both feel that way, that knowledge is power.
I love knowing more. I know. Okay,
and by the way, you got to find someone who will talk to you. Right? You don't want to be a nail who walks in front of a hammer. You've got to go find a practice and doctors who will listen to you and understand what your motivations are, and understand what your goals are, and put that all together for you. You don't want to go to someone who just knows how to do one thing, right? And that's really important. And that's something you're really good at. And, you know, if all else fails, talk to your patients, right? That's the most important thing.
Yeah. Well, and I think, listen, I'm going to say this till I'm blue in the face, right? Be proactive. So it's good to have people around that we can refer to. So now they're AMH. Tell us about AMH, because the biggest stimulus for this conversation was that a patient recently said, is AMH a predictor? Two things. One, of less likelihood of response to IVF, and is it a predictor of perimenopause, menopause, meaning earlier, I hate the word premature ovarian failure, but diminished ovarian reserve, whatever we want to call it. So is that something we need to think about or be concerned about?
So that's a lot of questions in one. All right, let me pull it apart. So let me just start off by saying the following statement. There is no AMH above which someone is guaranteed to have a baby, and there's no AMH below which you're guaranteed not to have a baby. Keep that in mind. Okay, let's there.
Right.
Now let's pull apart the first thing about perimenopause, and let's say natural perimenopause and menopause, because what you were calling premature ovarian failure or primary ovarian insufficiency might be a different term for it. That's a completely different issue. Let's just talk about natural perimenopause and menopause. All right. Yeah. So average age of menopause in the world, including the United States and the rest of the world, is about 51 and a half, 52. Yep. You know, right? About 95% of women are going to go through menopause between 45 and 55. Okay. Women who have their menopause from 40 to 45, that's called early menopause, right? And someone before 40 is called primary ovarian insufficiency. And that's really a very different medical kind of category and condition than just early menopause or perimenopause or menopause at the correct time. All right. So we're going to leave that out. That's a completely different talk that is really very specific. Now, can AMH predict when a woman is going to go into menopause if it's not 51, 52 is the average? So it's a very active area of research. So it's a moving target because literally as we're speaking, people are looking into it.
Right.
It's interesting, when Shieva and I set up this talk, I was like, no, it doesn't at all. And then I wanted to be prepared. So I did a little bit of research, and it turns out there's some newer papers like in the last maybe 18 months that really do show a relationship. Now you can't take an AMH at 25 and know when you're going to have menopause. It doesn't work like that. Right. When you're within about 10 years of menopause, age is a very important predictor of menopause, and AMH can help hone that in. So a lower AMH, probably 0.2 and below, 0.2 and below, probably indicates a menopause maybe within about 5 years if you're in an age group of I want to say something like, hold on, I have it right here.
You mean if you're older? In other words, a young woman with a 0.2 doesn't mean she's going to go through it.
There's no way greater than 10 years out AMH right now can predict menopause. So at 28, if you're 0.7, the answer is no. All right. Okay. If you're over 40 and you're very low, you're probably going to have menopause within about 5 to 6 years. And if you're very good, let's say 1.5 in your early 40s, it might be 10 years. Like that kind of prediction.
So it's still not helping. It's not helping me as a gynecologist in the perimenopause menopause realm, and it's really not changing anything I do with regard to young or older patients and helping them know what's going to happen.
That's well said, and I'll do you one better. You also can't use it when to say, hey, when am I old enough to not need birth control pill anymore, right? Or some kind of birth control. So you have a lot of 43 and above year olds that if you ask me, it's really hard to get pregnant after 43, right? But don't forget, that's who I see.
Right.
forget that. I see a very select group of people, but it's really hard to get pregnant 43 and above, just so you know, right? And so they all say, well, maybe I don't need contraception. I don't want to use condoms anymore. I don't need this IUD.
Oh, no. I tell them, I tell them they need it. So until you've had that year with no period, even if you're 54, I would tell you, you could get pregnant. It's unlikely, but you could.
Right. And AMH can't help you with that.
Right.
Right.
Good. So no, and I wouldn't even, I wouldn't even.
It wouldn't even come up in conversation.
Yeah. Okay. So PCOS, polycystic ovary syndrome.
Can I jump in one sec? There's a question you asked and get to, which was, does AMH predict response to fertility medication?
Yes. Sorry.
The answer is very much yes.
Okay.
That is actually locked down. That we know.
So let's repeat that. So a low AMH
will predict a less robust response to the medications I use to recruit eggs and follicles in fertility treatments.
Okay. In laywoman's terms, a low AMH means fewer eggs in an IVF cycle. Okay.
Less eggs, less embryos, less chances.
Different quality?
So, good question.
Right? Because, and let me just say this to like the crowd who doesn't know. So when you do in vitro fertilization, I know most of you guys know this, but you basically get stimulated with a lot of injectable hormones and sometimes oral hormones. And then Dr. Hurwitz or one of his partners goes in vaginally with an ultrasound and a needle and actually aspirates these little teeny eggs. And then they put them together with sperm and create embryos. So what's a good number at an IVF cycle, Josh?
So the average number of eggs that we retrieve in an IVF cycle in our practice is about 12. Pretty close to it. Of those 12 usually get about 3 or 4 embryos, right?
Okay.
But, you know, it only takes one, right? I talk to patients a lot. So some average is about 3, 4 embryos, but it doesn't mean there aren't people who get 6, 8 and there aren't people who get 0, 1, 2. Right. So low AMH is going to predict a lower response and will help guide me as to sort of like what strength of medicine and what protocol to give people, because there's sort of lower protocols, medium protocols, 10 out of 10 protocols, you know, things like that. Sometimes I have to throw the kitchen sink at patients due to their metrics. Right. And so that AMH will definitely predict a couple of things. They're going to have a big response or a low response.
Okay. Like, again, low response meaning fewer eggs.
Fewer eggs that can be recruited that will answer the message of the medicines we give.
Okay.
Right. Yeah.
And again, quality.
So quality is very much age related. The younger you are, the higher the quality. The older you are, the less quality. Now, quantity and quality tend to walk down the path together. So if you have very low quantity, regardless of your age, you'll probably have worse quality than you otherwise would than other age match controls. But still, age is the #1 biggest predictor of quality. So I would rather have a 30-year-old with low AMH than a 42-year-old with good AMH, right? Because I know that the quality of the eggs are going to be, I said that the wrong way, not rather. I just can predict a better.
We know what you mean. I mean, again, for the crowd here, just so you guys know, every year that a woman gets older, the quality of our eggs decreases, meaning the chance of things like Down syndrome or chromosomal abnormalities. It never jumps exponentially, right, Josh? So meaning when everyone freaks out about 35, it's not that 35 suddenly makes your risk jump exponentially. Every year it goes up a little bit. So a 43-year-old normal healthy woman still has more likelihood of eggs that will create embryos that might have chromosome abnormalities, right, than a younger woman.
So I could throw some numbers out there if you want, but basically you are right. So, you know, at about 35 years old, about 75% of the eggs left that a woman has are chromosomally normal. So that's awesome. That's where like the number 35 comes from, right? By the time a woman reaches 40, probably about 50% of her eggs left are normal and 50% are abnormal. Right. And by the time a woman reaches 45, I mean, like much less than 5%, like read between the lines there, are chromosomally normal. But it only takes one.
Right. Well, and something for our crowd, right, is when you say to the average person 50% at age 40 are abnormal, I don't want everyone to assume that means 50% of your babies will have Down syndrome, because the risk of Down syndrome at 40, I have to look at the chart, but I want to say is about 1 in 40 or 50.
Probably like even less common than that, I would say. Probably like 1 in 80 or 90, probably.
Okay. Let's round it up to 1 in 50 because I'm bad at math. If it were 1 in 50, it's still 98% of your embryos, meaning the baby, will be normal.
Babies,
right. So just to make that clear, even though 50% of your eggs won't work that well and won't get you pregnant, if you get pregnant, you have a 1 in 50 or 1 in 80, even better, risk of Down syndrome, just to make it clear.
Because that one embryo that slipped past the goalie, right? Like that's the golden one.
That was the good one.
Self-selected itself to be the good one and has made it through, ovulation, fertilization, growing to the blastocyst stage, implanting in the uterus, and then being okay through the first trimester. So it's self-selected itself to be a winner, reporting for duty in a good manner, so to speak.
Good.
Right?
Good.
Yeah. So Shieva, that's why egg freezing at younger ages is better, because you're freezing more better quality eggs. That's sort of like the idea about elective egg freezing. That's the idea.
So I want us to talk briefly about egg freezing, because I know it's a big subject, and I want us to talk about polycystic ovary syndrome.
Why don't we jump there first, okay? If you don't mind.
Yeah.
I saw a bunch of comments in here about that. So there's a very hot topic of research in reproductive medicine is what number of AMH can be diagnostic for PCOS. So for everybody out there, I know everybody out there knows what PCOS is. Polycystic ovarian syndrome is super common. 8 to 10% of all women have it. Is the #1 endocrine or hormonal disorder of women of reproductive age. Okay. At its core, just very, very briefly, I know Sheiva's taught you guys all about this already.
No, I haven't. I've done a couple of them and I'm still amazed. So I love hearing other people talk about it, because the people who do know me, and I say all the time, I don't care if you have PCOS. I hear it all the time. I see it all the time. But women are still fraught with anxiety when they say things like, you're going to tell me I have PCOS. And I'm like, yeah, I'm going to tell you because it's common. So I love when other doctors confirm this, that it is very common, not to be feared. It can be managed. There are definitely aspects of it that are frustrating and need help, but it's not a disease that is going to kill you or anything like that.
Wow, that's a beautiful way to put it, Shieva. I hope your patients just heard that. That was awesome.
I hope they heard it. Okay, but tell us your version of how would you describe PCOS?
8 to 10% of all women have it. At its core, just real quick, it's where the messages from your brain that tell your ovaries to ovulate are garbled. Right? So instead of the messages going free and clear to the ovaries to ovulate, it's a little bit like wah, wah, wah. And so they don't hear the message correctly. And so what do? Well, they don't hear it. They don't know what to do. They don't ovulate. Now, eventually, if you yell at someone long enough, they're going to listen, right? That's what I do when I get yelled at, right? So that's why the ovaries will irregularly ovulate and then irregularly have a period rather than usually no periods. But you can have no ovulations and no periods. So that's at its core what it is, right? And so we could do a whole hour on PCOS. That's enough intro. The idea with PCOS is that women who don't ovulate properly, the way I think about it, this is not a scientific way, but it's a good way to think about it, is that since the follicles and the eggs are not ovulating, they kind of accumulate, and women get these big ovaries chock full of all those follicles that never get to pop and go away during ovulation and let the eggs meet the sperm. So in my mind, I think of them accumulating, even though that's not really what it is scientifically.
Right. Wait, I'm going to interrupt for 1 sec just to like boil that down for our people here watching. Every month when we ovulate, that one follicle, which is the little bubble that the egg is housed in, gets recruited, we say, and pops to the surface and bursts and comes out. What Josh is saying, which I love because I always say the same thing. I always say, think of polycystic ovaries, which just means multiple fluid-filled pockets, as your ovaries, with a bunch of those little houses that never popped, so they're all just waiting there, right?
Love it. So I'll actually do you one further. Something that my patients, when I talk about PCOS, and I spend about like 40% of my day talking about PCOS, right? I'm sure you do too.
Because it's so common.
Right? It's very common. So the reason why we call it polycystic ovarian syndrome, it's a very scary term. Oh my God, I have grenades in my ovaries. I have these cysts. I have cancer. Absolutely not. No. So like in 1935, which is almost 100 years ago when they discovered PCOS, they didn't know what a follicle was. They thought every fluid pocket in the body was a cyst, right? They call it poly, meaning many, cystic, meaning fluid pockets in the ovaries, because that was a characteristic of the ovary in these women. If we were naming it today, we call it PFOS, polyfollicle ovarian syndrome.
Right. And which can't we do that? Can you just get your people to change the name? Because it's so annoying.
Well, there is a movement, and there's definitely people talking, and about every 10 years, the NIH convenes like a committee to like kind of talk about this stuff, and they get experts from around the world, and they say, hey, is this the decade we're finally going to change the name? And they haven't yet, right? But when I tell that to patients, you can literally see their shoulders go down, because they literally thought they had these chronic cysts and that they were going to get cancer or their ovaries were going to blow up. That's not what it is.
Not what it is. Yep.
Now,
multiple fluid-filled pockets.
Yes. Now, I could go super deep into the PCOS talk, but just vis-a-vis AMH, let's kind of bring it back to our topic tonight.
Yeah.
Since one of the criteria is having these big, huge, strong ovaries with lots and lots of follicles, And remember, the eggs and the follicles are what secretes the little bit of AMH, right? The idea is that a big, strong ovary is going to have higher AMH levels than a smaller ovary that has fewer follicles. That's where we started our discussion.
Right.
So there's a very hot research sort of development right now trying to pin a number of AMH above which you can predict PCOS and below which we cannot.
Okay.
Right? Below which you don't have PCOS.
Right.
So that number does exist. The research isn't great. It's not huge numbers of studies. The studies aren't like hugely robust. They're not all well done. Somewhere over 5, we can all agree on. If your AMH is above 5, it's sort of PCOS until proven otherwise.
Okay.
It doesn't mean you have PCOS if your AMH is super high, right? By the way, I don't know what like a 19-year-old's AMH is because I'm not checking 19-year-old's AMH. They could be 15, right?
I can tell you. Go ahead, and then I'll tell you what I think.
Right.
Go ahead. Mm-hmm.
But a number around 5 and above, you should start thinking about PCOS, especially if there are other issues going on, such as menstrual irregularity, hair growth, or acne on your face or your body, back-knee or chest acne or something like that, or a little bit more hair, like the pubic hair comes up a little higher than you want, stuff like that. So 5 and above. So there is absolutely a link between high AMHs and a diagnosis of PCOS. However, I do want to stress that it is not part of the diagnostic criteria called the Rotterdam criteria of PCOS yet.
Yeah, but it will be. Yeah.
I think it's coming down the pike. And some of the studies I looked at to refresh, to look at the most recent ones to prepare for tonight's talk, there actually are some studies where they swap out one of the Rotterdam criteria, which is an ultrasound criteria, and they replace it with an AMH criteria, and they actually got even better detection.
Good. And easier to do because not everyone can do the ultrasound, technically.
Right, or wants to, right?
I thought, by the way, the number was 3.5. Did that change? Or am I making that up?
You're not making that up. There's a few studies that were as low as 3. I think that's a little too low.
Okay.
I do think it's a little too low. And in that study, they said that they could better that it segregated a little bit better, but I think that's too low. I think everyone would agree in the whole research community that 5 and above, severely suspicious of AMH, and anything in the double digits is literally PCOS, even though that's like not.
And again, for those of you ladies who are on here, if you hear that you have PCOS, do not despair. I mean, I've said with confidence to patients, I have never had a patient with PCOS who did not ultimately get pregnant. Now, many of them get pregnant on their own. Many do not if they're not ovulating. So they might need help, but they will get pregnant. So when they Google it and they see PCOS and fertility issues, the concern is that they think they're never going to have a baby, when in reality, it just means you might need help, which who cares? If you need help, you need help. Like, let's bring it down to reality of what we really care about. We care that we'll never get pregnant. We don't care, or we shouldn't care, I would argue, if you need to have some level of help. Period.
Everybody needs a little help one way or the other. And I might say that I don't always really think of PCOS as an infertility problem.
Right.
I think of it as an ovulation problem.
Yeah.
Right.
Once you ovulate, you'll get pregnant.
Right. And so it's not like, think of someone who was having a period every month for 24 straight months and didn't get pregnant. Well, that's a real fertility problem. That's like, I'm already thinking about what's going on. There could be something serious, things like that, versus someone who's been trying for 2 years, but only had 2 periods, right? That's 2 eggs. And how do you time a random event over 2 years? And the sperm and the eggs aren't coming out to play, right? So
but you can get them to, which is the beauty. Like, that's why I can say with confidence with PCOS, if there is a problem that I can find and fix, I'm thrilled. And I can find it, and then I send them to you, and you guys fix it, because I don't want to fix that. But again, to reiterate to anyone out in the audience, do not be worried about PCOS. It's frustrating because the side effects are annoying sometimes, but even those can be managed in different ways. Yeah.
Maybe we'll do a PCOS talk, because I could talk honestly for like 5 hours about PCOS.
I could too. I could. And I do, because in the office, it's all the time.
Sure.
Okay. So here's another topic that I think is challenging, and then we're getting to 30.
Don't forget you wanted to get to
egg freezing. Right. Well, I'm gonna link these two. One is just, I need you to tell us in as brief way as you can, if everyone said, well, if I have the money, why not just freeze my eggs at age 25? Is that something we really want everyone to do? Is it a guarantee? I think the answer is no, but tell us, like, how much of a guarantee is a frozen egg going to be that I can get pregnant later? Should we be encouraging women at that age? In other words, should I say, listen, there's no downside. If you have the money, go ahead and do it. And the third question, which is a broader topic, and I wish like we could bring people to talk to us here, you and I, is I'm very torn about really, really aggressively encouraging every woman to think about this too much, because I want women to think about their future fertility because I don't want them to be frustrated. But I very much do not want women to feel so defined by their fertility, right? And I think that we are getting to an age where women are doing so much more than only being mothers. Yes, it is our genetic makeup and it's our pull to be mothers, and I'm thrilled to be a mother, though it drives me crazy. But I still think there's way too much pressure. So women, even who have achieved so many other things in their lives, feel so defined by their ability or inability to birth. And if we over address it, this is a very philosophical question. If we over address it, are we only adding more anxiety and adding more importance to the fact that women have more dimensions to them than birthing? Again, that's my concern. But so I think, tell us first about the egg freezing.
I tell this story to patients a lot. So my mother-in-law, she graduated high school, got married, I think like 2 months later, and had 3 kids before she was 24. Okay? Mm-hmm. That doesn't happen anymore, right? That doesn't happen anymore. Now, thank God women have educations and careers these days, right? It does come at the cost of delayed family building. And that's why that is the single number one reason why fertility services are required more and more these days. But thank God women have, career educations and careers. There's no doubt about it, right? No one should ever be defined by any one thing about their lives, right? If I was only defined as like being short and bald, I'd feel really bad about myself.
Right.
Like really. I mean, I know I am. Trust me, it's okay. Or if I was only defined by what I accomplish at work, which I love, and I'm like, it's like a huge part of my identity. If I was only defined by like what I can do in the gym or what I do at home. So no one should be defined by any one aspect. The problem, with fertility, is that it's at the core of who we are. It really tugs at the heartstrings, and it will cut through any intellectual argument that you could put up against it, right? The desire to reproduce, the desire to build your family, the desire to be like everybody else who didn't need help. That is a really strong desire, and one that I talk about every day. And it dovetails really well into what we're coming up with right now with the zombie apocalypse, as I call it, or the COVID-19 SARS-CoV-2 outbreak, is that fertility services are absolutely not elective. They are not non-essential, right? There's a clock for patients, literally, that is ticking. And to delay what they need to do right now might permanently impede what they want to accomplish.
Well, you should comment on that, because I don't know if everyone on here knows that as fertility groups, you kind of got mandated to close, right?
Right. So I will tell you that, just like everybody else in the world, we're not alone. Everybody got really scared, and first do no harm, and you don't want to cause any, harm to yourself, your employees, your patients, or society, right? So we all took a pause, and the American Society for Reproductive Medicine, which is our professional body, really came down pretty hard and very hard line saying no fertility services. And there's a huge backlash by patients and doctors alike. We all felt, that that's not appropriate for our patients. And everybody can make their own decisions and feel like if they can do it in a safe manner and not drain healthcare resources, right? So I'm really happy to say that we are up and running right now as of this week. So we were always doing emergency care. We were always doing Zoom consults. I think I've done more consults in the last month than I have in my whole life. Right. I'm like horse talking on Zoom all day long.
But now you're back to doing the procedures like retrievals and things like that.
Right. So exactly. So this is the very first week that we're doing diagnostics. That it's not life as usual. It'll never be life as usual. We know that, but no one knows when we're all going to feel comfortable to start up everything. I don't think we ever will. And to tell someone that they need to wait 6 months, a year, 3 years until the world goes back to normal is patently absurd. And I won't let any of my patients stand for that, because no one is telling anyone else there in the world that they shouldn't get pregnant. Right. So my patients shouldn't be told that either. So we feel very strongly about getting patients through essential and not elective. And we will fight to the
Actually, so you just brought up a good point. So I still want to circle back to the egg freezing and what is the likelihood of a 25-year-old and should we encourage it? But if you have a nugget, all my patients and all people that I don't know but are on Instagram keep asking me should I not be trying to get pregnant right now? Not with fertility, I mean, but just on their own, should they not be trying? What do you say?
Well, I'll tell you the joke, then I'll tell you the real answer. First of all, the joke is don't get the virus, right? That's the joke, right? Okay. So, here's what we know at this point, and I'm sure you speak about it more eloquently than I do, Shieva. As of right now, there's no evidence at all that the virus itself is what we call teratogenic, meaning causing birth defects. That if you were pregnant while you had it and your baby wouldn't come out with 3 heads. It's not what we're talking about.
So good. Repeat that, because I don't use that word teratogenic, but guys, that means that it would not cause a birth defect. It is not a known teratogen. Good.
It is absolutely not. So that it's limited data, but there are publications coming out in Europe and in China right now that there doesn't seem to be any birth defect or bad baby problems. We do not think that. Now, it's still an unknown field, but we don't think that. Now with Zika, right? Remember the good old days of Zika? Zika, right? Oh, I can't go to the Caribbean, right? Like the good old days of Zika. There was very quickly we found that it was hugely birth defect, causing, right? The mothers did fine, but the babies didn't. Now with the SARS-CoV-2 or the COVID-19, we actually think it perhaps is the opposite. No teratogenicity. However, it is plausible, although not proven yet, and the evidence does not support it. It is at least plausible that pregnant women might be a little bit more susceptible to getting it. Right. And if they get it, it would be plausible about it being a little bit worse on them because of the immune system of pregnancy. Kind of like the flu. Women, influenza A and B, they get it worse in pregnancy.
Though it has not been as bad as the flu, interestingly, for pregnant women.
Correct. Right. So it's plausible to think about, but I'll be very honest with you. The evidence has not borne that out yet. We haven't seen that. It's plausible.
Right.
Now, here's what I would also say is that if, God forbid, a pregnant woman did get COVID badly, and was in the hospital like you hear on TV right now, right? Or if anybody's been touched by this, and we all know people who have, right? The medications they use in the hospital a lot of them are not okay in pregnancy. So I think that's the crux of the matter. But I'll be frank, there's not one professional society, there's not one governmental agency, there's not one Department of Health, there's not physician group. There is no one out there who's telling anybody not to have a baby and not get pregnant right now. At all.
And I've said, by the way, to a lot of patients who've asked, like, I don't think you should not try. I think it's fine to try, but I think my concerns with it right now are if you know yourself and you're particularly anxious and every other second you're doctor Googling what's going to happen as you're trying to get pregnant with COVID being around, and that's going to make you crazy nervous, then wait a month or two till we have more information. But I wouldn't medically say that you can't get pregnant, because people are getting pregnant and they're okay. So
I absolutely agree with that. Now, I do think that the same things apply, like hand washing, don't go out, all the same things that we've talked about are very important. But I agree with you 1,000,000%, Shieva, that for the rest of your life, you shouldn't really, you can't put off what's important in life. You just absolutely can't do it. And I spend my day talking to patients who spends a lot longer than they want trying to get pregnant. And so who knows how long it's going to take. So if you take 6 months, 9 months, a year off, well, that makes it even harder and has put you back. So
well, especially because COVID is not going to go away. We're going to live with it now, but we're going to know more. Yeah. Okay, so tell us about, again, if it were your sister, she can afford it, let's say. You don't have a sister, but I'm just saying. And she says, well, why not? Is there any downside to egg freezing? And if I freeze my eggs at 25, is that a guarantee that I'm going to be able to thaw them when I'm 45 and have a baby?
So good question. Let me give you a little bit of background on egg freezing. So egg freezing has been around for about 9 or 10 years in its current good form. Before about 10 years ago, we were not good at the technology didn't exist called vitrification to freeze eggs well in a good quality. So if you didn't do it back then, don't beat yourself up because it wasn't good, right? The technology came out of trying to help women who, God forbid, need chemotherapy, like for breast cancer or other cancers, to try and be able to freeze their eggs and help them with fertility preservation. So through that great research of the whole like onco-fertility sort of research community, vitrification of eggs has become a really great technique for freezing eggs. All right. In order to
and Josh, sorry, I know I'm interrupting. Just to reiterate to you guys, if you don't know, embryo freezing, meaning you take the egg, you take the sperm, you put it together and you freeze it, has been around for since the first test tube baby. But Josh is talking about just freezing the egg, because when the egg thawed, it didn't work, right? Before 10 years ago.
Right. So exactly. So just the old slow freezing technology didn't work well, but because the egg is a very finicky cell, it's actually very hard to freeze, thaw, and use. Right. Mm-hmm. It's a very finicky cell. Now, let's see. So egg freezing is the important point you made, though, is that, like, here's a simple statement: men have sperm, women have eggs. Together they make embryos, and an embryo becomes a baby. Now, if a couple came to me and they wanted to freeze embryos, right?
Mm-hmm.
The embryo is sort of joint custody of that couple, and he can't use it without her, and she can't use it without him. And believe me, that's like been divorce things, been arguments. That's I want a baby, I don't. The whole Sofia Vergara thing, like that's a thing, right?
Right.
However, if a dude freezes sperm or a woman freezes eggs, they have sole custody of their own gametes and their own reproductive potential there.
Right.
So the best thing I can say about egg freezing is it not only preserves your future fertility, it maintains your reproductive autonomy. You don't need any dude to help decide what you're going to do in the future. You still get to decide.
Right. But
that's the beauty.
But am I right in when I say, but if you are in a relationship that you believe you will be with forever, you will have better odds when you frozen embryos than freezing eggs. Is that right?
The math is a little bit different, but I will say embryos are a little harder to freeze and use than eggs. But like, can we maybe put that on the side? That's like a very technical question.
Okay, done with that. Now we're going to talk about eggs.
Talk about who's a good candidate for egg freezing and who's not. Okay, because I think we're getting to the crux of what you want to talk about right now, Shiv. So basically, anyone who wants to freeze their eggs should and can. Okay, the optimal age for freezing eggs, probably depending on who you talk to, could be as broad as 30 to 40, could be as narrow as 32 to 36. I think of it as 32 to 38 is kind of like the ideal age, and I'll tell you why.
To freeze?
To freeze eggs.
I did not think you'd say that. I thought you would say younger.
Well, the younger the better, but hold on, Dr. G.
Yeah.
So let's say, someone came in and they're like, my eggs are only as good as they're going to be at 26 years old. Let me freeze them now. Why not?
Right.
Well, you are right. That's it. Your most eggs, the highest quality, you will do better with that. However, you're so young that you might not ever need to use them, and you might have gone through that whole process for not.
Okay,
right?
but that's the only concern, is that it's a waste of time, money, energy, and discomfort of injections and everything.
Right.
Okay.
Correct.
Okay.
So when we talk about the whole package of not just this technology of it, not just the science of it, but who uses frozen eggs, who needs to freeze eggs, 32 to 38 is sort of the sweet spot, because if you're too young, I mean, you might not ever need them.
Right.
Right. You're 25 years old. You're worried about it. You get married at 29 and you have your first kid at 31, your second one at 33, and maybe another one at 36. You might not ever need them.
Right. Right.
Now,
I got it.
The reason why I say up to about 38ish, and that number is that can move. Right. It doesn't have to just be 38. As you get older, what we talked about, the quality of eggs goes down very steeply. Right. Mm-hmm. So the speed at which chromosomal abnormalities increases doesn't just go like this. It's not a straight line. It actually goes like this. And so as we get older, the quality of the eggs goes down. And so over, let's say 40, the quality of the eggs might not be ideal enough to want to freeze them. And there's not as much less of a guarantee or an idea that you can expect a kid out of that. And you would need a lot more eggs to do the same job, because a lower percentage of them are going to be chromosomally.
Are going to be okay.
Right?
Right. And is there an AMH, getting back to it, under which you can't freeze your eggs? Or are you going to say it's not just your AMH, it's the whole picture?
I love it. It's not just the AMH, but it will predict response. So let's say the AMH is lower. I'm not going to get a ton of eggs in one cycle.
Okay.
Right? It's going to predict response to the medications, but it would also guide me to use higher doses and to counsel that patient appropriately, that it's not just going to be maybe not just one cycle. She might need to do 2 to get enough eggs, things like that.
Okay.
So that brings me up to another concept. How many eggs do you want to freeze? How many feel good to be frozen?
Right.
So again, it's going to be age-based. The younger you are, the fewer eggs you need. The older you are, the more eggs you need, because of that percentage of them that are chromosomally normal versus abnormal. Right. So it's a sliding scale where you paradoxically need more when you're older, which is exactly when you get fewer.
Right.
Right. Now, the magic number is about 15. 15 and above eggs, people feel really good. There's at least a baby or 2 in there. That feels really good. Okay. Under 10, not an awesome number. You definitely want double digits. Now, I have definitely frozen fewer than 10. I definitely have patients who come in, give me 3, 4, 8. Some people do it another time. Some people don't. Some people have time to do it again. Some people have funds to do it again. Some people are getting into chemotherapy at that point. That's why some people do this. Right. So you take what you can get, right? But the idea is that any one egg, depending on the age group, but let's just do broad numbers of like the whole population, any one egg probably has about a 5 to 10% chance of being a baby.
Okay, I know. You got to repeat that. That is bizarre to me. That just sounds so low. One
Well, let's think
egg
about it.
has a
Let's think
5 to 10% chance of becoming a baby in the
your
lab.
correct.
Because we're not talking about in our body. That just seems bizarrely low.
It's actually probably lower in the body, to be very frank.
Right. I would think in the body it's low. I would think you guys would have a better rate.
Yeah. So the idea being is, like, let's say there's about a 95 to 97% thaw survival of eggs when you thaw them. Okay.
Right.
So not everyone does, but most of them do.
Okay.
And then, like, let's say you go to use them. So how do you use these frozen eggs in the future? Well, they will be fertilized with a future sperm source. So let's say you're with Prince Charming or using donor sperm or whatever, right? My wife would argue there's no such thing as Prince Charming out there, right?
I'll agree with her.
Yeah. Well, no, come on. You're the exception, Shieva. You know that.
I am Prince Charming.
Charlie, that's Charlie. That's
not Charlie.
Prince.
Yeah.
So the idea is that you're going to use a sperm source where you're going to inject a sperm directly into each egg, and there's probably about a 70% chance of fertilization. So 96, 97% thaw survival, 70, 75% chance of it fertilizing normally. And of those ones that fertilize normally, probably about 40 to 50%, let's say 45% of them as a round number, are going to make it to the embryo stage. Each of those embryos is going to have something like a 50 to 60% chance of being a baby. Let's say in our lab, it's about 60%. We have really high rates. So let's say about 60% chance of being a baby. So let's just do some numbers. Let's say we started with 10.
Right.
Let's say 9 thaw, even though it's 90%, even though it probably would be 10 out of 10, but let's just say 9.
Right.
Of those 9, say 7 fertilize normally. Let's say 45% of that's going to be 3 or 4 embryos, 3-4 embryos at max. That's 3 chances at 50 to 60%.
Right. So you can't say to a 25-year-old who freezes 10 that you can say she's likely to have a baby, but all in, what's the percentage number that you're saying to her? You're going to have a baby X% with that 10 eggs.
That's where the number 15 comes from. We feel really good if there's 15 eggs that they're going to have a baby.
Okay.
We definitely feel good.
A baby,
right?
Not 2 babies necessarily, just 1.
You know, you always want to under promise and over deliver, right?
Yeah.
But you are like, so that brings up a very good point. So is egg freezing an insurance policy or a guarantee of a baby? The answer is no, right? Let me tell you what I mean by that. So let's say, like, I have homeowners insurance on my house, right? That's insurance. That means if my house burns down, God forbid, I am guaranteed a certain amount of money to rebuild my house, right? It's a guarantee. If A happens, B happens. I get B. Well, I don't know if egg freezing is exactly the same way. Right? Yes, you freeze your eggs, but it is not an absolute guarantee that you froze your eggs that you're going to have a baby.
Right.
Now, it is risk reduction of not having a baby by the best science has to offer. Right?
Okay. Right.
It's absolutely not a guarantee or an people throw around this term insurance policy.
Right.
And I even say it sometimes to myself, but I always put it, hey, look, an insurance policy is a little different. You're guaranteed to have this if you do this.
Right.
Now, look, if you're like 32 years old and you give us 15 to 20 eggs, you're going to have a baby. You're going to have a couple babies. I'm not, I say it like this, but I do counsel patients up front that there is no guarantee. It is risk reduction of not having a baby as much as possible. Right? Now, the converse of that is, let's say you don't freeze eggs and let's say you're 35 years old, you're married to your job instead of some dude, and you don't want to use donor sperm to get pregnant right now. You want to wait for the sort of the traditional way to build a family is have a man in your life, so to speak, right? Instead of using donor sperm. And you come back to me finally at 43. Hard to get pregnant at 43, even through IVF. So the chance of having a baby with those 35-year-old eggs that you have frozen is way up here.
Okay.
Where the chance of getting pregnant and having a baby with 43-year-old eggs is way down here. Right down here. And so it is risk reduction by as much as possible, or hedging your bets as much as possible. But any doctor who promises you an outcome, who guarantees you a baby, or says egg freezing is a guarantee or an insurance policy, is trying to sell you something much like an insurance salesman. Right?
Okay. But so overall, it's something that we should discuss more, especially as we learn more. Though, I mean, again, we only have 1 more minute. I think they're going to cut us off. So let me just say this. I would love to have another conversation about PCOS, and I'd love another conversation about what we think about women trying to get pregnant all the time. But Josh, thank you so much. We could talk, as you guys can all tell, we both love to talk, and we could talk for hours about all this stuff. But you guys go to Josh's. Josh has his own Instagram, but he's not on it as much, but on fertility_RMA CT. So it's RMA Reproductive Medicine Associates. They're amazing. And I love you. Thank you for doing this. You guys, I hope you enjoyed it.
Shiva, thanks for having me on. I just feel like my personal cup has been like filled up by being with you
Good.
and all your patients,
Perfect.
all of our mutual.
Okay.
Okay.
And I'm going to save this if it works. 10 seconds remaining, so we're going to say goodbye so that I can save it. Okay, Josh, thank you.